Often small hospitals may not have an ID pharmacist and they may not have an ID physician. So they have to work within the confines of what's available locally and potentially consult externally to help them with their program. And that can be done in a number of ways. Statewide programs, if they work in health systems where they can rely on the resources of the healthcare system. But ultimately, execution occurs at the local level. So whether or not you have an ID pharmacist or an ID physician, you still need to have someone in clinical pharmacy and some physician champion locally that can help execute the recommendations if you have to outsource that kind of drug expertise. Well, telemedicine is a way in which you can outsource, where you can actually physically see a physician, you can actually see a patient through telemedicine, and it's a nice way to connect if you like to connect visually as well as by speaking. As opposed to just doing chart reviews electronically. And some people find that to be much more engaging than to just have someone looking at chart reviews and having phone consultations. So it really depends upon your setup, what's available to you. I think the key thing is if you don't have the local drug expertise, that there's ways in which you can get it, whether it's by telemedicine or by other ways. The important thing is that we get that information down to the clinicians at the bedside so that we can improve patient outcomes. And the key thing is that just because you're a small institution does not mean you shouldn't have a stewardship program, and that we know from studies that have been published that antimicrobial resistance is not limited to large referral hospitals. It's also found in smaller institutions, and it's everybody's responsibility. And so I think the key issue is that we're all in this, we're all part of the solution. Small hospitals, large hospitals, I think they're all important. Smaller hospitals, you have to start off literally small and try to build on that. So you certainly can have post-prescriptive review where you have a 48 to 72 hour timeout, if you would. And you can target certain antibiotics, or in a small hospital you may want to target every patient that's been started on a new antibiotic. Look at what the site of the infection is, look at what the pathogen is, see if there's an issue that you can de-escalate to a narrower spectrum, or perhaps stop antibiotics if no infection has been identified. So all institutions can do that. You can have restrictions if that's possible. Sometimes it's more difficult in a small hospital to have restrictions. You can certainly look at days on therapy, a consumption metric. You can look at adherence to guidelines. You can look at acceptance of recommendations from the stewardship team. So these are all things you can do, and you can also, of course, look at cost. So these are things that all small hospitals can do.